the last two lectures that were still remaining. I'm understanding that you just had your review session, so hopefully this should go a lot faster than usual. So there's two lectures. The first one is imaging of common malignancies, and the second one is interventional radiology. So we'll start with this one because the other one builds on this one, okay? If you have any questions, you can type in the chat. If anything is not clear, please let me know. If I'm going too fast, ask me to slow down all of that. So let's start. So regarding these two lectures, the most important thing is to be able to have some idea of how all of this is done clinically. Yeah, it's fine if you didn't attend the review. I don't exactly know what happened in the review, but should have been helpful, inshallah. Okay, so over here, what we're going to talk about is some common malignancies, and then how we judge them or we identify them radiologically, and then staging. Okay, so firstly, let's give you the basic idea of how cancers work. So back to POD. Basically, you have an abnormality. There is some sort of, increased division of cells, which is abnormal, and we call that cancer. So the first thing that we do is, before even the, how do I start this? Okay, so basically, whenever a person comes to the hospital, they come with some symptoms, right? They have something wrong with them, and then they show up to the hospital. So the first step in catching a cancer is known as screening. And in this step, we ask the person to come in before the symptoms are seen. So they come in for a regular checkup or for some other checkup, and we call this screening. So we have some imaging modality to be able to detect this cancer in its early stages. So it's done on the normal population, okay? Now, let's say once we have something that was screened to be positive, then what we do is make sure that this is a cancer or this is some other benign thing, okay? So that's known as diagnosing the cancer. And in this, basically what we do is either we go for a better imaging to find out more details, or we take a biopsy, right? And once we have a biopsy, we understand what type of cancer this is, and we have like a definitive diagnosis. We know exactly what's wrong. And then we go for treatment, right? So in treatment, we have various ways of treatment. So the most common is, either surgery or radiotherapy or chemotherapy, right? So when we go for surgery, before we go for surgery, we have to find out the extent of the disease or how far it has spread. And that's known as staging, right? So for staging, we use some other imaging modality. It's usually CT CAP, which is CT, chest, abdomen, and pelvis. Or we could use an MRI, or we could use the PET scan that you guys studied earlier, depending on where we think the cancer may have spread. Okay, so after staging, when we come to treatment, before going into surgery, we may also use radiology again. This is known as pre-surgical evaluation, okay? So the reason why I said the whole story is that radiology is used in a lot of steps in the workup of a cancer, okay? So it's very important to know which stage of the workup we're talking about, and it's really important to know which specific modality is used in which stage, okay? So let's start. So breast cancer is one of the most commonest malignancies in KSA. It has a very high mortality. It's the most common cancer among women, leading to death. So we go for screening, right? So again, what is screening? We test normal individuals who we think are at high risk to be able to catch the cancer early, to be able to have better outcomes of the treatment, right? So usually it's done on an annual basis. Mammography is used. So what is a mammogram or mammography? It's basically low resolution or low energy X-ray of the breast, okay? So what do? They do an annual mammography of anyone who is 40 years old and they are asymptomatic in this stage, okay? Then after that, once you do suspect that something is wrong, you go to the diagnostics phase, where you're actually either checking up for an abnormal screening, or someone already came to you with a breast lump or bleeding or pain or something, you know, they have some sort of symptom, and then you do the diagnostic approach, you know, which is not mammography, or it could be mammography, or it could be something else as well, okay? Or if someone comes with a prior disease of breast cancer and you want to really diagnose again and see if it's breast cancer or not, okay? So for screening, the first thing we're going to talk about is screening, okay? For screening, there's usually two views. So first view is known as craniocaudal view, and the second view is known as medial longitudinal oblique view, I think. Yeah, medial lateral, something like this, MLO. Okay, so for the craniocaudal view, so one thing to note about this is screening, so there's no symptoms. The second thing to note is that what is the orientation, right? So the breasts are divided into 4 quadrants. There's the outer, upper outer quadrant, lower outer quadrant, and then upper inner and lower inner, okay? So when we're looking at the craniocaudal view, basically what we're seeing is the breast from the top, okay? So this is the outer quadrant, and this is the inner quadrant, okay? So basically we're looking at it from the top. And the second thing to note over here is that we don't know what is normal and what is abnormal until we compare both sides. So this is the right side, as you can see, this is the left side, and basically what radiologists do is that they see both of them and compare to see if something is abnormal. If something is present in both in the exact same spot, then that probably means that it's a normal finding, you know. Now, the second view is known as the mediolateral oblique, or longitudinal, one of those, I forgot. Anyway, so what they're doing over here is that they took another view, and this is basically a lateral view, okay? And the reason why they want to do this is that they want to include some part of the axilla, and this thing that you see over here is the pectoral muscle. And when we take this view, what we see is this is the upper half and this is the lower half, as you can see over here, okay? So basically it gives us an oblique type of view, something like this, and we're able to see another view of the breast, okay? So these two views give us a clearer picture. Now, breast density. So remember how we said mammography is used for screening in women who are greater than 40 years old, 40 or greater. So the reason is that younger women have more dense breasts, and since they are greater in density, it's harder to be able to distinguish abnormalities using an X-ray. So mammography is not usually used for those women. In case we do suspect breast cancer, we would go for diagnostics, not imaging, not screening, okay? So again, they talked about how it changes over the lifetime. So they get more fatty over the lifetime and less glandular. And when they become more fatty, it's easier for us to be able to find changes on an X-ray, okay? So over here, what they're talking about is BI-RADS. So BI-RADS, it stands for Breast Imaging Reporting and Data Systems, okay? Basically, it's a way of all radiologists telling other clinicians what class this scan is. By class, I mean how likely is it to be cancerous, okay? So you can just read this. There's nothing much. They don't go into the details of BI-RADS over here, so I'm not going to go into them either, okay? So this is just showing an example. If a woman is lactating, she's going to have very dense breasts, so it will not be able, they won't be able to pick up abnormalities easily. Now they're giving you examples of benign calcifications, right? So these large dots spread throughout, these are benign calcifications. And if you can see, these are, you know, along the vessel. So these are vascular calcifications. Basically, you should be able to look at this image and know that this is not cancerous, okay? So again, now we have benign and now we have cancerous, okay? So how do we know if something is cancerous in a mammography? basically you would see them very close together, and it would look like a spiraculated mass, which basically means it has irregular edges and it's really nasty looking, you know. So this, as you can see, is denser, it has irregular edges, and then you see that there's focal points of a lot of small calcifications, okay? So this is generally going to be a breast cancer, and this is the image that you should be most aware of. Okay, next you have microcalcifications. So the thing with microcalcifications is that they're very, very small, right? So these also give you an indication that they could be a cancerous lesion. So once they zoom in, they see these tiny, tiny, tiny microcalcifications. Once they see this, now they have to go into the diagnostic phase where they actually do the other tests to make sure if this is cancer or it's just, you know, just an incidental finding. Okay. So let's say we have an individual and they have this breast mass, this lump. Okay. They come in for a screening, and this is probably a young individual because you can see that there's a lot of density around it, right? So this is probably a young individual, and they do a mammography and they see that there is a lump. They find a lump over here, okay? So then what would be the next step? So since this is a young individual, and we said that, you know, you can't really tell much on a mammogram, they would move into the diagnostic phase, which is they want to know if this is cancer exactly or not. So in this phase, they would go for an ultrasound, okay? So this is the second important image that you should know about. So this is an image, an ultrasound image of the breast. And basically this image is invasive carcinoma. Carcinoma basically means cancer, and invasive, so you know it's really bad, right? So what are the features over here? So you can tell that there is an area of hypoechoic area over here, all of the way over here, right? And there's calcifications. So calcifications basically means this area of increased brightness that shouldn't normally be present over here, okay? Then they say it's lobulated or circulated or ill-defined borders. So ill-defined borders is the easiest thing to make out. So you can see that this is all very ill-defined. It's not round. You can't really make out the border exactly where it starts, where it ends, right? So this messy thing over here points more towards a malignant image. And then we have anti-parallel or vertical to chest wall. So basically what they're trying to tell you is if anything is benign, so this is the orientation of the tissues generally, right? You can see the lines oriented like this. So if anything is benign, it will most probably be in the same orientation. Whereas if something is malignant, we know that extra cells are proliferating, they're causing a lot of dysplasia, leading to neoplasia, so they're going to be messy, right? So the orientation of the whole tissue may be vertical, okay? So again, this is an image. This is a mammography. This is the craniocaudal view. This is MLO. So basically they found a mass over here, right? So now once you found a mass and you suspect this is cancer, what is the next step you would do? You would go for more detailed imaging. So the more detailed imaging is going to be an MRI, right? But usually when you're diagnosing breast cancer, you don't go for an MRI because it's very expensive, you know, all of that stuff. So usually what they do is they take a biopsy if they are suspecting cancer. So they would take a biopsy, and usually it would be, usually the biopsy would be under ultrasound guidance, okay? So basically they would take a needle, they would go all the way to the lesion, and they would extract a few cells, and then they would look at it under the microscope, and then they would grade the cancer to know if it's actually cancerous or not, and then to know how bad the cancer is, so grade 1, 2, 3, 4. So grading is done under pathology, and staging is done with the radiological images, okay? So this is an extra picture that I added just to give you a better idea of what a malignant lesion looks like. So basically it's going to be a mass which is hyperdense. It's different from the surrounding areas. If you compare the other breasts, it's going to be different. And this is the medial lateral oblique. Okay, so it's called lateral oblique view. And again, we see that this is, you can't really tell, but you know, the borders are not very smooth. It's rough, it's spiraculated, and then there's, you know, tiny microcalcifications over here as well. So again, once you find this on screening, then you go to the second imaging modality, which is usually going to be an ultrasound guided biopsy. And this is why, this is when you will see either this image, or if it is benign, you would see this image, okay? So now they're talking about the breast cyst. So this is a benign image. And what are the features that points towards a cyst over here? So this is, again, first of all, this is ultrasound. So you can see that the borders are very, very round. They don't appear to be irregular. You can easily differentiate between, you know, when a structure is starting and ending. You know that it's fluid filled. Why? Because there's really, it's anechoic or very dark black. And then you see the posterior enhancement. So you know that there is something which is less dense and it's showing up brighter in the background. So you know that this is fluid filled, right? So this is a normal cyst, and this is a benign finding. So you could find something like this, and then once you do an ultrasound to really, you know, figure out if this is a problem or not, you see something like this, and you're like, oh, okay, yeah, I don't need to worry. I don't even need to take a biopsy, right? Sometimes you may find an image like this. This is known as a fibroadenoma. It's basically a benign mass. Okay, so the clinical description you're going to get for this is it's going to be a young female, probably, you know, 30s to 40s, who has a complaint of a mass, and this mass increases or decreases in size with her periods. Okay, so this points towards it being estrogen dependent. The more estrogen there is, the greater in size it's going to be. Okay, and they're going to describe it as not being attached to the underlying surfaces. So if on examination, if they try to palpate, they feel that it's moving around. Okay, that's going to be the general description of this if they bring this in the scenario. So what are they going to show you? Most probably they're going to show you an ultrasound image like this. Why? Because it's a young female, so the breasts are dense, so they're going to use an ultrasound. Okay, so what are they going to do? What are going to be the findings over here that points towards this? So again, it's well defined. It is parallel to the chest wall. So remember, the last one was vertical, the cancer. This one is horizontal, so it's along the other structures. It has smooth borders, and you know that it has some sort of mass over here, right? It's not completely black. So there are some masses. There may be some calcifications, so bright spots over here. You may be able to see them, but since this appears to be, you know, very smooth border and all of that, this is most probably a fibroadenoma. Okay. So now what they're trying to tell you is that on a mammogram, you may see calcifications like this, which are very clear. But, you know, once after a mammogram, once you're screening with the mammogram, after that, once you go with the ultrasound and you go into more details, it may turn out to be a fibroadenoma. Okay. So again, just to make sure that you have understood the sequence of events. So screening is always without any symptoms. And for screening, you always do a mammography if the female is 40 years or above. Okay, less than 40 years, we don't usually screen. If we have to screen, if we think it's a high risk patient or something, we'd go with ultrasound. Okay, why? Because the breasts are dense, so it's easier to differentiate structures on an ultrasound. Next, once we suspect that there is something wrong, we would go for an ultrasound. Why? Because we want to biopsy the patient. So if we see on the ultrasound that there is nothing to worry about, we would probably not biopsy. If we feel that there is something wrong, we would do the ultrasound and we would take a biopsy sample during the ultrasound as well. Okay. Okay, so this is, again, just to summarize, this is a cyst. It looks very, you know, benign because the borders are well circumscribed. It's dark. You can see the posterior enhancement, so we know that the cyst. This is a benign condition. We don't need to work it up further. Over here, this is a fibroadenoma, which is also a benign condition. It has some solid parts, but it has some, you know, fluid-filled components as well. It may have some calcifications. That's why it may be detected on a mammogram, because over there we can see the calcifications because that's X-rays. But again, it appears to be having well-defined edges, and it's parallel to the tissue structure. So this is fibroadenoma. This is going to be a very nasty looking picture. You can't really tell what's going on. Where did the border start? Where did it end? You may see some calcifications. Maybe this is over here, but they're generally in an opposite direction. So this is vertical, anti-parallel to the, or perpendicular to anti-parallel, perpendicular to the other structures. Okay. Now, this over here is known as sentinel lymph node biopsy. Now, so we know that once cancer spreads, breast cancer starts spreading through the lymph nodes. Okay, so there's a lot of lymph nodes in the axilla and other regions around. Okay, so what they do is once they do suspect a cancer, they want to know if it has spread to any other region or not, right? So usually what they do for staging in most cancers, in breast cancer as well, is what they'll do is they'll do a CT, chest, abdomen, pelvis, and then they may do an MRI if they're suspecting a metastasis to the brain and stuff like this, right? Sentinel lymph node biopsy is to know if it has spread to the surrounding lymph nodes. What they do is they basically inject a dye near the tumor, and if this tumor is spreading, or let's say they inject the dye, and since the dye will drain through the lymph nodes which drain this tumor will be lighted up. Okay, so they know exactly which lymph nodes will drain this tumor. Once they know exactly which lymph nodes will drain this tumor, then they will go and biopsy all of these lymph nodes to see how far they have spread. If they find that it has spread to more than one lymph nodes, they may, surgically excise the whole area. If they find that, okay, the first, second, third lymph nodes are fine, they may just excise this area. By excision, I mean they may perform surgery to remove the area, okay? So that's where sentinel lymph node biopsy comes in, just to know how far this tumor has spread locally, okay? So that's everything about breast cancer. Do you have any questions so far? My two amazing participants. Or would you like me to move on? We do a mammogram if the patient is above 40 and ultrasound if it's less than 40. Okay, yes. So again, there is screening and then there is diagnosis. So for screening, yes, mammogram above 40 or above, ultrasound less than 40. Usually ultrasound, you would not screen patients because cancer usually develops in the older ages. But if needed, then you would go for an ultrasound. For diagnosis, it's most probably going to be an ultrasound. Why? Because they need to take a biopsy to look at it under the microscope. Cool? Make sense? So over here, the most important, again, for diagnosis, they may use an MRI as well, but it's not included over here in your slides, so just forget about the MRI part, okay? Why MRI? Because you'll be able to see the soft tissue in more detailed and you'll be able to know exactly where to go for surgery and stuff, okay? So don't confuse yourself with MRI. They only included 2 images, so the only images that they have included for you guys are mammograms, so something like this, and these 3 images. No, these 3 images, no, this image, where's that image? This image over here, no, this image, and you're good to go. Cool? Okay, now let's move on to the other cancers. So they don't go into much detail about this. So again, what they're trying to tell you is, first of all, this is an ultrasound and they're talking about thyroid now, right? So usually if you have a thyroid problem, the first imaging that you would do for thyroid is always going to be ultrasound. Why? Because it's a soft tissue, it's located right here. You can just do an ultrasound and see a lot of details, probably better than most other imaging modalities for a diagnosis, okay? So there's no screening for thyroid. This is just for diagnosis. So you see a swelling, you suspect something is wrong, and then you do ultrasound for diagnosis, okay? So this is mentioning a benign cyst. So again, this is the trachea. This is the butterfly shape around it. So this is one of the lobes. And it's showing you a cyst. So how do you know if it's a cyst? It's, well-defined, circular. You can easily tell the margins apart. It's black. There is usually posterior enhancement. You can barely make it out over here. Versus this is a nodule. How do you know this is a nodule? Again, it's going to be, it looks pretty benign, right? So it's a nodule, but you can see the edges very clearly. You can tell them apart. It doesn't have any irregular borders, but you know that this is not a liquid because there is gray color over here, right? So we know that this is a nodule. So what they'll do is they will take under this ultrasound guidance, they will take a needle, they will do a fine needle aspiration, remove a few cells and look at it under the microscope to know exactly if this is cancer or not. Then secondly, to know what type of cancer this is exactly, okay? Okay, so these 2 are important. Basically for thyroid scans, if you use an iodine 123, okay, so how does this work? Basically, we inject iodine into the patient's blood, and we know that the thyroid gland uses iodine. So it will take up this iodine. And since this is radiologically active, we can see it under imaging. Okay, so when we do a scan, we'll be able to detect if it is being taken up by the thyroid. So usually if they want to know if the thyroid is working properly or not, they would use iodine 123. Okay, this is just for diagnosis to make sure if this is working or not. However, in some cancers, when we know that the thyroid is being overproduced and we want to basically kill the whole gland, what we use is iodine 131. Okay, basically this is way too heavy for the thyroid to process, and this will lead to the thyroid to stop working completely. So the good thing is that these patients don't have to go for surgery, don't have to excise the whole gland, don't have to wait post-op, there may be complications, blah, blah, blah. You can just inject thyroid into the vessels, and we know that the iodine, we can just inject iodine, into the vessels. We know that it will be taken up by the thyroid. It'll go all the way to the thyroid. It will damage the thyroid because it's going to be radioactive, and it's going to damage the whole structure. So the cancer will be effectively destroyed. Okay. So again, the numbers are really important. 131 is for ablation. How does it ablate? You know, it emits a beta decay, which is dangerous for the body. Whereas over here, there's only a gamma decay, which is dangerous, but it's usually removed very quickly. Okay. So next, we are moving on to renal masses and renal cancers. So again, this is an ultrasound of the kidney. We can see that this is a cyst. Why is this a cyst? Again, it's black, well-defined edges, posterior enhancement. Okay. Whereas over here, this is most probably a cancer. How do we know this? Or this is a mass. You know, we can't say if it's cancer or not. But this is a mass. It's solid. It's gray. You can easily tell the edges apart. So again, it's probably a benign mass, but we're not sure. So we have to work at the tumor further. Okay. Now, this is a CT. So if someone asks you, someone presents with a renal problem, okay? And let's say their symptoms are going to be, it's an old man who is complaining of difficulty urinating, and he feels flank pain, you know, pain on the left or right side, and there's blood in the urine. So what do you think the first thing that comes to your mind is going to be? The first thing that comes to your mind is going to be cancer, okay? Kidney cancer. So what you're going to do, if they ask you what is the initial imaging modality that you'll use, you'll always say ultrasound. Okay, why? Because it's cheap, it's available right there. You can just see the kidneys and see if there's a mass or not. Okay. Now, once you have seen that there is a mass, something like this, and it looks, we can't really tell if we know it's not a cyst, right? So it could be a benign lesion, could be, and could not be benign, right? We want to make sure if it's cancer or not. So we go for diagnosis. For diagnosis, what we're going to use is CT. Now, as a rule of thumb, generally, whenever we are suspecting a cancer, we're most likely going to use contrast. Why? Because the contrast is injected into the blood. We know that the cancer cells are going to uptake the blood because they're using a lot of oxygen. So when we see it under the scan, we're going to see the pathology light up. And if it lights up, we know that this is most probably cancer. Okay, that's why they inject contrast. So over here, they injected contrast, but this is a cyst. This is a CT scan, by the way. So they injected the contrast. These are the two kidneys. This is the vertebra. This is the, again, spinal cord is somewhere over here. This is the vertebra. These are the back. This is the front. Okay. So over here, we can see that this is a cyst because there's no uptake, and you know it's relatively smooth borders and all of that. Whereas over here, this is huge. So this is the normal kidney where it was supposed to be. And this mass is extending out of the kidney. It's invading the other structures nearby. It's really large. And you can tell that it's lighted up, right? It's lighter than the surrounding area, right? It's lighter than this as compared to this. So we know that it's taking up the contrast, okay? And also we can see that it is, also we can see that this is heterogeneous. So there is some tissue over here. It's not really fluid. Yeah. By the way, I think there's no contrast over here for some reason, because if there was contrast, you would see these vessels light up. Okay, so I think there's no contrast. They're just showing you solid versus liquid over here. Okay. Anyway, moving further to ovarian cancers. Any questions so far? Yes, 131 is for treatment and 123 is for diagnosis. You're right. Okay, so ovarian cancer. Now, again, if they ask you ovarian cancer, what's the first or the initial modality that you will use? You would say ultrasound. If they ask you what is the best modality or most appropriate modality, anything like this, then you would go for MRI. Okay, so over here, wait, quick recap. So for kidney, if they ask you what is the initial imaging modality, you will say ultrasound. If they ask you for a kidney stone, okay, again, kidney stone can also present with flank pain and hematuria or blood in the urine, okay? If it's really acute, it happened like a few days ago and it suddenly happened, it's a person is in a lot of pain at once, there's bleeding, it's a young patient, it's most probably going to be a kidney stone. Whereas if it's an old patient, happened over a long time, you know, then it's probably cancer. Either way, the first step that you're going to do is ultrasound. And then in case of a cancer, if they ask you, you would go for a CT. Yeah. And if they ask you what is the best imaging modality for a kidney stone, you would say non-contrast CT, okay? Because you can see the kidney stone without giving contrast. Contrast will take time, it has a lot of other problems, allergy, stuff like that, okay? Okay, moving on to ovarian cancer. Again, the first imaging modality, if you're suspecting ovarian cancer, it's going to be an ultrasound. So over here, they're showing you a trans-abdominal view. So this is the uterus. This is the ovary. This is the ovary again. And this is the, this is another view, I'm guessing. So again, they're trying to point to, this is the ovary over here. This is the bladder. As you can see, it's full of fluid. It's a rectangular shape. And this is the uterus down here. Okay, both of these are trans-abdominal views. Okay, so what they're trying to show you over here is that this is a, okay, this is so weird. One of them should have been a transvaginal view. Anyway, so now over here, what they're showing you is a transvaginal view, okay? And again, they're showing you the ovaries over here and the ovaries over here. Now they're moving on to pathology. So now what they're showing you is an ovarian cyst. So how do you know it's a cyst? Again, it's circular, doesn't appear to have rough, irregular edges. However, this is a hemorrhagic cyst, which means that this was fluid filled and then it got filled with blood. So there was hemorrhage somewhere, okay? So this is probably the blood that they're trying to show you on an ultrasound. Again, you know, this is a hemorrhagic cyst, and now they're trying to show you Doppler. So they're trying to show you that there's blood flowing around, but over here the blood is stagnant. Okay. Okay, so now they're talking about an ovarian cancer. So this over here, this is most probably the bladder, right? Because it's rectangular, it has a lot of fluid. When they say complex cyst, I'm assuming this is what they're trying to show you. And they're trying to show you that this is spreading around. Or I could be wrong, and this is just a complex cyst of an ovary which has expanded so much that it's taking up this entire space. You know, I'm not sure. Complex cyst with positive Doppler. So over here, it's a lot clearer. This is the complex cyst that they're trying to show you, and this is the Doppler over here. So why are they doing a Doppler? Because they want to show you that there is movement of blood over here. Okay, so basically movement of blood points towards blood vessels being present, which points towards most probably a malignancy. Okay, so what happens in ovarian cancers usually is that there's some sort of cancer, and due to that cancer, it causes fluid accumulation in the abdomen, and it can lead to ascites and stuff like this. So again, I think this is most probably they're trying to show you ascites or something like this. But they labeled it complex cyst, so I'm not sure. Okay. Now, either way, whenever you do an ultrasound of the ovaries, you suspect that it's a cancer. What are you going to do? You're going to go for MRI. Okay. Now, in the MRI over here, what they see is this is a T2 image, right? So in T2, remember how we said T2 is always without contrast? It's used to look at pathologies, and you would see fluid light up. So over here, what we see is there's fluid that's lighting up. Okay, now they want to make sure if this is cancer or not. So what do? They insert contrast. So contrast, again, is always given with T1 because this is looking at normal pathology, normal anatomy, not pathology, so T1. The only thing that will light up over here is the contrast, so fluid from the contrast, and it shows you that, somehow, this is the ovary. Okay, so they show you that contrast is being taken up over here, so this is most probably an ovarian cancer, okay? Okay, so now they're moving on to the endometrium. So basically they're moving on to the uterus. So again, they show you properly a trans-abdominal view. So this is when you place the catheter, the probe on the abdomen, and you see a trans-abdominal view. So you can see the urinary bladder over here, and then you can see the uterus underneath, and it looks like this shape over here, right? When you're doing a transvaginal view, the first structure that you encounter is the cervix, and then you can see this whole uterus again. The bladder is somewhere over here on top, and this is the pouch of Douglas. Okay, so basically what they're trying, again, this is a normal transvaginal view. What they're trying to tell you over here is that there may be fibroids in the uterus. Okay, so fibroids are this growth of the uterine wall, which may be cancerous, which may not be cancerous. You can't really tell. Fibroids are non-cancerous, okay? It's usually benign. However, this may be a cancer. So again, woman comes, with pain, irregular menstruation, whatever, you aren't sure if there's a mass or not. So you do the first imaging that you do is an ultrasound. You see some sort of mass over here, or you see some sort of mass over here. So you think you have to rule out if it's cancer or not, so you go for further testing or workup, whatever, okay? So this intramural basically means inside the muscle wall. So this is the muscle wall of the uterus, and they found a mass inside the muscle wall, so it's called intramural. This is subserosal. So remember how there's layers of each organ. So when you have the serosa or the adventitia, if the fibroid is over there, then we call it subserosal because it's right underneath this area, and it's causing this whole area to expand. So it is subserosal. So the serosa has spread out all over like this. Okay, so we know it's fibroid. How do you know it's fibroid? Well, first of all, it's in the uterus, so it's most probably a fibroid. And secondly, you can see that there is solid structures over here, as well as maybe some fluid component over here. This is a picture that I added just to make life easier for you. So you can see that if it is a intramural fibroid, it's present inside the muscle. Okay, if they're talking about subserosal, it's present right underneath the serosa. So this is serosa, this is right below it. Okay, just to make sense out of this. Okay, so next, the image they're trying to show you is the endometrial atrophy, and basically what that means is after a woman is what's it called, postmenopausal, then the uterus will shrink and there'll be atrophy of the wall. So it'll be smaller in size, it'll be more grayish, and you can't really tell the walls apart as easily as you can over here. So you can see this is dark, this is very light over here. Over here, it's very, very thin, and you can't really tell the difference much between the walls, okay? Then you have endometrial cancer. So what did they do? They suspected a mass over here. The first thing they did was a Doppler, and they found that there is a lot of blood vessels over here, which obviously, like honestly, they'll find anywhere else in the uterus because it's so vascular, but sure, they did it with the Doppler over here, cool. So that they're basically showing you what an endometrial cancer looks like. So any questions so far? I think the most important thing to know out of this is if you're suspecting any problem in the uterus, the first thing you're going to do is an ultrasound. And again, it could be a benign lesion, could be a malignant lesion. You just have to work it up further. How exactly? I'm not going to go into the details of because it depends on a lot of things. Okay, it could be an MRI, could be a biopsy, whatever. Okay, don't go into the details. Basically, you should be able to know if this is a normal, uterus, or if there is some abnormality. If you see this, this is definitely abnormal. I don't think they'll bring you this, honestly. I don't think they'll bring you this either. This they may bring you and mention to you, this is the uterus if you see something like this, which is clearly abnormal. you would know that, it's probably cancer. So over here, I think it's just image recognition that you have to do, pattern recognition of images. Okay, moving on to lung cancer. Any questions so far? See, in these lectures, what I'm trying to do is just give you some more clinical background, because you guys haven't covered this before and the questions are mostly clinical. And I'm focusing on just looking at the findings, seeing if you're able to identify it, and what imaging modality you'll use if they bring you a question of diagnosis versus screening. Okay. Cool. So let's move on to lung mass, lung cancer. So lung cancer screening is usually done. Okay, so what is screening? Again, it's when you don't have any symptoms. So a person just comes to you for a normal checkup. So lung cancer, the way you would screen for lung cancer is going to be a low resolution CT. Okay. So if someone asks you, do you screen for lung cancer with x-rays? The answer is no. Okay. Now this over here is basically a patient who came with symptoms, so probably coughing or something. And they didn't chest x-ray because that's the first thing you usually do, because it's cheap, available, all of that. And you saw this mass. Break. Do you guys want a prayer break real quick for like 10 minutes for Salah? I was thinking we can finish this before the prayer break, but sure. How much is left? 10 slides. Okay. How about I give you guys a prayer break? Let's make life easier for you. I'll give you a prayer break and we'll continue in 10 minutes. Okay? So we will get back at 7:10. Okay? And then we'll continue. You guys can. So talk about cancer. So let's say we who was symptomatic chest x-ray and they found this mass over here, right? And we're suspecting lung cancer. So what's the first thing that they do? They do a CT scan, okay? And again, since we said this is cancer, so they would do a contrast enhanced CT scan. Is my voice clear? Because I'm getting the message of unstable internet connection. Anyway, so for diagnosis of lung cancer as well as screening of lung cancer, we use a CT scan. The only difference is that for diagnosis, you're going to use a contrast enhanced CT scan. So what they see is this huge mass over here, so it's irregular, it's nasty looking, all of that. So it's most probably lung cancer. Okay. So now, what's the next step after seeing this lung cancer? After diagnosing this lung cancer, the next step is going to be biopsy, right? In which they actually take a sample of this and look at it under the microscope and be able to tell if this is actually cancer or not. Okay. Now what they did was they did all of that and it turned out to be cancer for sure. And now they are staging this, right? So now they're trying to find out how far it has spread. So this is a PET CT, and basically this is the cancer location, and then these lymph nodes are lighting up, which shows that this has spread to other areas, right? So over here you can tell that this is further down, and this is the pelvic floor, something like this, and it has also spread over there. This is lower down, I'm assuming. So they're going from top to bottom, okay? So what they're trying to tell you is that for staging, they use a PET CT, and you can see it lighted up, okay? And then again, this is just PET scan. Over here, you can also see that this original cancer, which was in the chest cavity, has also spread to the adrenal mass over here, okay? So this is how it looks on a transverse view, and this is how it looks on a transverse view. This is how it looks on a sagittal view, okay? So again, this is an adrenal metastasis, right? And then they're showing you what a normal adrenal gland would look like. So adrenal glands, remember, they are triangular shapes. This is a very bad image, but sure. And what they're trying to show you is that if it is having a cancerous lesion, it's going to be somewhat, again, disturbed, hazy, irregular borders, all of that. Okay, so for screening, this is probably important. So for screening, the first thing that you do is that you scan the local area to see if there is any local metastasis. And if you're also suspecting a distant metastasis, then you would scan the whole body, okay? So there's a couple of ways to do this. The most common, the one that you learned about firstly, is the PET-CT or the PET scan, all of this, okay? What's usually used in practice is not this, but rather a CT cap, which is known as CT of chest, abdomen, and pelvis. Why do they use this? Because it's cheaper, more widely available. Not a lot of hospitals. I think only KFSH has PET-CT over here. Okay, so it's very expensive as well. Then, if they are suspecting a lesion in the brain, they're also going to do a brain MRI. Why? Because CT can't really pick up a metastasis, because CT does not have that much resolution when it comes to looking at the brain. Okay, so again, we want to know if it's lymphatic versus hematogenous. So we know this by the different organs and the type of cancers that are usually there. If it's more distant metastasis, it's more deadly, so higher mortality or survival. Yeah, so over here they say that it's recently being used more often, right? Why? Because it's very expensive. Okay, so depending on the anticipated sites of metastasis, so some cancers where they're going to spread. So most commonly for lung cancer, these are the regions where they spread. Okay, they're actually not only for lung cancer, for many cancers, because also for breast cancer and stuff. So the sites of metastasis, so again, if you're looking for the bone, you can do a PET-CT or you can do a bone scan. If you're suspecting the brain, you would do an MRI of the brain. If you're suspecting a lung cancer metastasis to the lung cancer, or like from some other organ to the lung, again, you would do a contrast CT. And if you are suspecting the liver, you would do a liver CT scan of the liver. Okay, so this is just showing you bone. So bone scan, bone metastasis, this is normal, this is metastasis. Why is this white over here? Because most probably they're shielding this area. Okay, so it's a white shield over here. So now they're suspecting a metastasis to the brain. So this is a person, again, with lung cancer who they think they have metastasis to the brain. So they do a T2 image. T2 image, they see a lot of free-flowing fluid and they see this abnormality. So what do? They do a T1 with contrast. And once they do this, they see that only the contrast has lighted up. The free fluid is now suppressed because this is T1. And they know this is metastasis. The contrast they use is gadolinium for MRI. Okay. Again, over here, they do a contrast CT. These areas light up, so they know that this is a metastasis to the liver. They're saying that usually abdominal malignancies, they metastasize to the liver most often. So the question is typically going to be of colon cancer. If a person has colon cancer, what are you going to do? You're going to do CT of the liver. If not CT, what are you going to do? MRI of the liver. Why? So why, if colon cancer and these abdominal cancers, they spread to the liver first? Because all of their blood supply, it first goes to the hepatic portal vein, portal hepatic vein, that one. And then it goes to the IVC and stuff. So that's about it, about the first lecture. Do you have any questions so far? So the most important thing, again, is to know, screening versus diagnosis, initial modality versus, definitive modality for diagnosis versus screening, and also just recognizing if it's cancerous or not. They're going to bring you very simple images, and hopefully this is easier for you to understand this way. Now we're going to move on to our last lecture, which is probably one of the easiest lectures, called interventional radiology. So radiology in hospitals is basically having two branches. One is diagnostic, one is interventional. Interventional is basically the cool type, which earns a lot of money and is very, very competitive. Okay, so basically intervention means any procedure. So any procedures which are done using radiology, it comes under interventional radiology. So over here, it's very simple. She has made a very simple slide. It just tells you an indication, advantages of this versus normal surgery. and the uses, which are case-based. So these are the three main uses of interventional radiology. So we can use it to diagnose, make sure of our diagnosis. It could be used therapeutically for treatment of a disease, and it could be used as pre-surgical. Pre-surgical basically means when you're going for surgery, you always need to do a lot more imaging to know exactly the location of the pathology. And we may use interventional radiology for this procedure, and we'll talk about how. Okay, so what are the advantages of using interventional radiology versus traditional surgery? So one, it's less invasive because usually you just go through the blood vessels and there's no deep cut, so there's less pain and there's overall less risk of bleeding, anesthesia, all the surgical post-op complications. Usually you don't have to stay admitted in the hospital bed for a long time, so less costly for the patient as well as the hospital. They have more beds available for others. And sometimes they're saying that image guidance is better than actual visualization, especially if something is very hard to reach. For example, there's a tumor in the brain which is very deep down. It's much easier to go through blood vessels and reach it as compared to going for a whole surgery of the brain, cutting open the brain and skull and all of that. Okay, so the three main uses again are diagnosis, therapeutics, and pre-surgical localization. So here they're giving you examples of vascular versus non-vascular. So vascular is usually going to be through the vessels and non-vascular is outside the vessels, okay? Cool, so vascular interventions, that's the first thing they start talking about. So the first thing they're talking about is claudication. Suspected PVD. PVD stands for peripheral vascular disease. Claudication basically means atherosclerosis, right? So there's plaque building up on the walls of the arteries and it's making it difficult for the blood to flow, right? So what we see over here is this is normal. So we can see the walls are, blood is flowing normally and the walls are well defined. Whereas over here, there are thick walls, so there is thinning of blood flow over here. So you can see areas where the blood flow is less than usual, and these are indicative of peripheral vascular disease. Okay, so what are the types of intervention we can do? So this is diagnosis, right? So where does interventional radiology come in? Interventional radiology basically comes in when they go through the blood vessels. So basically they go usually through the femoral artery. So they'll go through the femoral artery and somehow they will reach this area. So this is the iliacs. They'll reach this area, and once they reach this area, they will place a stent over here. The stent is basically like this metal spring which will open up the vessel and it will allow blood flow to keep on going. Okay, so that's where the intervention part comes in. Next, we have uterine fibroids. So we already talked about fibroids. It's a benign abnormal growth inside the uterus. Okay, so the cool thing about fibroids is that they require a lot of blood supply, and if they require a lot of blood supply, what we can do is not go in surgically, because again it's going to be difficult, lots of bleeding and stuff. We can go in for certain cases via the blood vessel, and we can embolize the artery. If we embolize the uterine artery, the blood supply of this fibroid will be blocked, and so this fibroid will die off. Okay, other regions may still have the blood supply because there's left and right uterine arteries, and there's also collaterals and stuff, but the main supply will be stopped. So embolization basically, it basically means that you insert some sort of material such as glues or something that will cause clots to happen, and basically we're blocking off the vessel over here. So we're essentially doing the opposite. Over here we're opening the vessel, we're placing a stent, a spring-like thing to keep it open. Over here we are purposefully destroying this part, clotting this part, blocking this part to block off the blood supply to the fibroid. Okay, so again over here they're showing you pre-embolization, so you can see that there's a lot of blood flow over here. This is the uterus, these are other vessels, and then again this is the wire that is reaching all the way here. So you can see that this is the wire, and then from here on they insert the contrast for us to be able to see, and this is after embolization. So we see that the blood is no longer flowing to this region, right? It was flowing all the way to this region, to this fibroid, whereas over here, this is, you know, it's stuck over here, and all of this supply is blocked, so it will die off. Okay, so paraganglioma, again, it's a vascular tumor. So it's usually right beside the vertebra, right? And it's usually neurological tissue. What's it called? Neural tissue. Okay. So again, what we do is we block off the supply. So pre-surgical embolization. Why is it called pre-surgical? Because we embolize and it gets rid of the blood supply. And even if it does not kill the entire tumor, it will still reduce the size of the tumor, which will make the job of surgery later on easier. Okay. So again, first they locate this. They locate it during the procedure. Okay. And another thing is, sometimes it's very difficult to see where the pathology is with the naked eye. You know, the tissues, they don't really look different while you're doing surgery. So if you have a pre-surgical scan done, it's very easy to localize the pathology as well while you're operating, right? So over here, this shows you pre-scan. Over here, there's a lot of blood supply to this ganglioma. And then after that, after embolization, when they insert the glue or something that causes clotting or fibrosis over here, there's lack of blood supply. So this area is no longer lighting up. This is pre-surgery, okay? Chemoembolization, so basically they have some sort of chemical which causes embolization, like a glue or something. So over here, they're trying to show you chemoembolization of a liver tumor. So liver cancer is happening over here. They use chemoembolization for this, for certain types of cancers, okay? So that's the vascular component done. It's very simple, very easy. You just need to know the application of this. So non-vascular tumors. So we talked about the palpable breast mass, right? So now they're going to go case-based. So that's good for us because this is most probably it's going to come for you guys, right? So describe the lesion. Again, this is probably a benign mass, benign carcinoma of the breast. Why do you think this is the most likely diagnosis? Because of, you know, irregular borders, vertical as compared to horizontal, tissue, irregular mass, maybe some calcification, right? So what is the next step? After you think that this is most probably a cancer, you would go for confirmation. How do you confirm? You would do a biopsy. How would you take the biopsy? Under ultrasound guidance, right? So the next step is to just take a biopsy from this ultrasound. Once we have confirmed the diagnosis, then we'll think about surgical resection, okay? So the first step is percutaneous biopsy. We won't do a follow-up because we think that this is malignant. If we thought this was benign, we may follow up in 3 to 6 months, okay? Okay, so what we do is percutaneous biopsy. So over here, you can see that this is the ultrasound probe, and this is the needle that they're using. So they can see exactly where they're going, and then they will draw out some cells and then send it to pathology, okay? Now, this is a palpable breast mass. So this is another patient who comes in. She can feel a lump somewhere. She can palpate it. And what do you think this is? So this over here, just from seeing it visually, it's most probably not cancerous. Why? Because, you know, it's horizontal as compared to the other tissues. It's in the same direction. It has some solid component to it, but from the 3 previous pictures we saw in the first lecture, this is most probably fibroadenoma, or it could be a complex cyst. But let's go with fibroadenoma. So what is the next step? Again, you would go with percutaneous biopsy because it could be cancerous, right? It does have calcifications. We're not 100% sure. So we're going to do a biopsy either way. When would we follow up? In 3 to 6 months, if this was a simple breast cyst, okay? When we'd go for surgical resection, we would never go for surgical resection right away, okay? The next step is always going to be either biopsy or follow-up. So in this case, we want to make sure of the biopsy. So again, we go do an ultrasound-guided cyst aspiration. Okay, so it was apparently a complex cyst. So we do an aspiration, we send it to pathology. Pathology helps us out. Okay, now what do we see? We see an abnormal mammogram. So what do we see? We see a spiriculated lesion. We see that it has rough borders. There's a lot of calcification that we can see. It's in one precise area. We see that there's calcification in one precise area. So this is most probably a cancerous lesion. So what do you think the most likely diagnosis is? It's malignant breast cancer or breast cancer, you know? do they think ultrasound guided biopsy is appropriate? What other biopsy options are there? So yes, ultrasound guided biopsy may be appropriate, but other biopsy options which may be available are going to be what's it called? Mammogram or mammography guided ultrasound. Okay, so basically they're going to okay, the example where this could be used is basically there is some microcalcifications, but there is no breast lump. In this case, since you can't really see the lump, when you're doing the ultrasound, you may not see many microcalcifications, you may not see a lump. But since you see these microcalcifications, you are still suspecting breast cancer. So what do? The only way where we can actually visualize this is by the mammogram, right? So what we're going to do is mammogram guided breast biopsy, and then you would send it to pathology. Okay, so what's the good thing about mammograms is that it covers the whole breast. So if there is microcalcification spread throughout, you can get it, you can see the whole breast clearly on the mammogram. Versus on the ultrasound, you're probably going to see it only like one fixed location, depends on how you move the probe and all of that. Okay, so usually when you have a papillary mass, you would go with ultrasound. If you don't have a papillary mass, only microcalcifications, you would go with MRI. You would go with, firstly would go with mammogram, then later on you can go with MRI, but again, you can't really see calcifications on MRI. Okay, so this is just a flowchart from AMBOSS just to help you guys make sense of breast cancer, because this is most probably the type of question you're going to get, right? So once we're doing screening, once we know that the patient, okay, so this is not screening, okay? Over here, we're talking about a papillary breast mass. That means that there is a symptom of this breast mass. So what do? If it's greater than 30 years, we'd go with mammogram. Why? Because the breast is mostly fatty over here, so we can see it easily through the mammogram, and we can see the whole breast, not just one precise region. And we can palpate the mass over here, so mammography is good over here as well. Now, on the mammogram, if we suspect something to be suspicious, if it looks bad, if we can see irregular borders, we would do a biopsy. And then once we do a biopsy, it'll tell us if it's benign or malignant, okay? However, if the patient is less than 30 years old, you would usually, the first line is going to be an ultrasound, followed by a fine needle aspiration. Over here, if you suspect it's cystic, it's clear fluid, you would just follow up because you think that this is benign. You just tell the patient, come back after 6 months or so, just to see if it has progressed, increased in size, something like this. If you feel like, no, it could still be a mass or cancer or something, you would go straight to biopsy. And then biopsy will confirm if it is benign or malignant, okay? Hopefully this gives you a better image, better overall idea. Now, if there is no papillary mass, it is just screening, then what would you do? You'd only do mammogram for greater than 40 years old, okay? This is symptomatic, that's why it's 30 years old, don't be confused. And if you are suspecting breast cancer in someone who is less than 30 years old or 40 years old, you would go for an ultrasound. But in that case, it is diagnostic, not screening, okay? Okay, so over here, what they're trying to show you is, again, this is about intervention radiology, right? So now they're trying to show you that you can also aspirate a joint if you suspect a swelling. So this is probably a patient who came with some trauma or something, or they're suspecting some sort of infection, they're suspecting fluid buildup over there. So what do? They aspirate the joint. Basically, it means that they go under ultrasound guidance. They take some fluid out of the joint. So either they want to make a diagnosis, they want to see if it's an infection or not, you know, or they want to just get rid of the fluid to be able to make movement easier. You know, it could either be for diagnostic or therapeutic purposes. Either way, you're going to use interventional radiology for this, okay? So this is just to help you with the labeling. So basically, this is most probably fluid buildup over here, right? So this is fluid buildup in the synovial fluid. Again, this is probably, you know, left knee. This is probably the right knee. That's why it looks different. But this is the closest image I could find to help you make standing structures, okay? This is just for your own knowledge. Okay, so the next case they bring is lung lesion. So basically they were suspecting lung cancer and they did a CT scan. Once they did a CT scan, they saw this spiraculated nodule, which was irregular and all of that. So they think that this is a lung cancer. So what is the next step? Before you go for a resection, again, the next step is to be able to diagnose and see if this is actually lung cancer or not. It could be benign lesion, right? So what they do is percutaneous biopsy. So once they're doing percutaneous biopsy, they take a needle, and so this is still a CT scan. They'll take a needle and they'll go for a biopsy. So metal is very bright on a CT scan. They know exactly where they're going, and then they'll take a sample of this thing over here. Okay, that's where the intervention part comes in. Okay, now this over here, they're talking about interventional radiology used for pre-surgical localization. Okay, so the concept over here is that if a lesion is pretty big, when you are doing surgery, if you cannot see it visually, like, if the tissue does not look different, the cancerous tissue from the normal tissue, while you are performing surgery, how will you tell it apart? So if it's large and palpable, most probably you can actually feel it while you're doing surgery. Okay, this is a hard mass, this is most probably our cancer. Okay, but if it is a very small lesion, if it's a very small mass, but there's a mass, there's a cancer, but it's very small, how would you, during surgery, tell which area I have to take out? What they do is, if they suspect it's very small, less than 1 centimeter, what they will do is, first, using a CT guided interventional radiology method, they would go all the way to it, okay, using the blood vessels. So they would go through the blood vessels all the way to this region over here, and they would place a tiny coil over there. Okay, so this coil is made up of metallic spring, right? So once they're going for a surgical procedure later on, they can just feel the lung and they would know, okay, so this is soft and this is hard, because the spring is in that region, right? So once they know that this is a hard region, this is where the spring was, this is where the coil was over here in this case, they would be able to resect that. Okay, so interventional radiology comes in while the surgical resection is going on, or before the surgical resection, to be able to localize the lesion. Okay. Okay, so elderly patient with obstructive renal stones, worsening renal function. Okay, so they tell you this, and this is again an ultrasound. This is most probably hydronephrosis. How do I know this? It's because this is the place where the calyces are usually. It's full of black fluid. It's enlarged. So there's probably some stone downstairs, which is causing a backward flow and stopping the urine from being excreted, right? So what is the most probable diagnosis? It's most probably a uteric stone. What is the next step? Okay, so in this case, if they ask you what is the next step, you know that this is most probably a stone, right? Now, sometimes a stone may be too big and it may have to undergo surgery or something, but the patient that comes to you in the ER is in a lot of pain, right? He's having groin to groin pain, he can't sit still, and he is just miserable. So what they can do is they can do a percutaneous drainage, which will get rid of all of this fluid. Percutaneous means through the skin. So what they do is they literally go in from the skin through, and they insert some sort of drain, and that drains the fluid. Once that fluid is drained, all of this distension, all of this swelling, all of this increase in size, which is causing a lot of pain, will be reduced. So at least the patient will no longer be in pain. Okay, so what they do is they insert a drain, because urine can now flow out, right? So they insert a drain from the skin all the way to this, and they get rid of the obstruction. Okay, so there's backed up urine, and all of this flows out through this percutaneous drain until they figure out what to do with the kidney, until they schedule a surgery or whatever. Okay, so basically it's this coil-shaped needle, and they insert a guide wire inside it, and which straightens it out. Once they straighten it out, they can insert it like directly using, over here they're using an X-ray. So they insert it and they know exactly where they're going, and then they remove the guide wire, and then it just coils up. So once it coils up, it can't be easily removed, right? So that's how they're able to drain the kidney. Okay, now lastly, I think this is the last one, or we're very close to the end. So this is a thyroid lesion. So again, what do you suspect? It's most probably a thyroid nodule. What's the next best step? You are going to always, once you're doing an ultrasound, you will confirm to make sure if this is cancerous or not. So what will you do? You will do a percutaneous biopsy. Now, if this was just if this was just a thyroid cyst and you're not suspecting anything cancerous, what would you do? Either you can do a fine needle aspiration, not for diagnosis, but for therapeutic purposes, just to get rid of a lot of fluid which has accumulated, or you can just tell the patient, you know what, this doesn't appear to be dangerous. We'll just follow you up and check again after 6 months to see if it's increased or not. Okay. In this case, what would you do? You do a percutaneous biopsy. So again, we're doing a fine needle biopsy just to make sure what type of cancer this is. We're taking some of the culture of the cells, sending it to pathology. Okay. So again, if you have a thyroid nodule, the first thing that you're going to do is an ultrasound of the neck, and then you would do an aspiration to send to cytology to see if this is cancerous or not. Okay. I removed the other half because it's not for you guys right now. Okay, next, if we're suspecting a renal mass. So remember how this is a CT scan, this is one kidney, this is the second kidney, and you see that the mass is extending all the way outside the kidney, right? You can see that this is probably a cancerous lesion. So what is the next step? So now over here, when it comes to renal cancer, after you've made the diagnosis, okay, first the diagnosis was made most probably using a contrast enhanced CT. Okay, once they have made the diagnosis and they are sure of this, then what's the next best step? You have to confirm this is a cancer or not, right? So the thing is, with renal cancer, you know how with a renal cancer, the renal arteries and renal veins are in very close proximity to it. So generally, a biopsy is not recommended, okay, because it can just spread the cancer everywhere. So it depends on the location of the tumor, the size of the tumor, a lot of other studies, a lot of other parameters to know what is the next best step. So the doctor over here wrote it for you already. All are appropriate treatment options, okay? Could be a nephrectomy, which basically means that they remove the whole kidney. Could be a percutaneous biopsy, so they just do through the skin, they go in and take a biopsy to make sure if it is cancerous or not. Could be radiofrequency ablation, okay? And I think this is what they're going to focus on. Okay, so enhanced renal tumor, this is for diagnosis. They give a contrast tumor. They give a contrast, IV contrast, and they see if it lights up. If it lights up, you know that this tumor is taking up blood, and it is taking up a lot of blood, so it's enhancing. So we know that this is we can diagnose this as most probably, still not definitive, as renal cancer. Okay, let's say they know it's renal cancer for some reason. Okay, they know it's renal cancer. They can do two things. One is that they can just resect the whole thing, or they can do radiofrequency ablation. What they do is they apply radiation to this region over here using CT scan, guided by CT scan, so they know exactly where they're firing, and they can get rid of this mass over here. And the proof of this, they show in image C. Post ablation, there is necrosis. So once they do the CT with contrast again, you can see that none of this, the contrast is taken up. So you know that this region is no longer alive. So there is necrosis over here now. So they got rid of the cancer, basically. This is really cool because you can actually see the radiation, which is being fired at a particular spot. Okay, and that's about it. So this is more towards just giving you an idea of what interventional radiology is used for, very, very briefly. And then just, again, you know, some more clinical stuff about the cancers, because that's how it's going to usually present to you guys. Do you have any questions after this? I'm sorry, this was a very dry session with not much of, you know, it's just me trying to justify or give you more information about the clinical aspects of the cancers, because that's how, you know, the questions are going to be, just know the images, what they look like under the different modalities, have an idea of what to do for screening, what's initial, what's best management. Always remember that whenever you have finished the screening, you always have to make sure if this is cancerous or not. So you would most probably use some other imaging modality to be able to get a biopsy. Okay, and that's about it. If you have any questions, please ask me. If anything was not clear, please let me know. After exam, I would highly, highly, highly appreciate a feedback. It helps us improve. It helps us know if we were actually helpful or not in the PALs or not. And yeah, thank you so much. Hope you have a great exam.